how familiar are you're messing me up. How familiar are you with chest tubes?
I'll say
Pretty familiar. You've worked here for
I set them up.
a long time. Okay. So the main things that you really need to be focused on are the orders, right? So if a patient comes up to the ICU and they're hooked up to suction, they're hooked up to this tubing, right? That goes to our canister. It goes to the regulator on the wall. The regulator on the wall, do you know what we set that to?
Yes.
So you set it to regular, okay? And if you ever forget how much to set it to, you can actually look on the back of the chest tube. So anything greater than 80, okay? If they're hooked up to suction, that's what it needs to be set. Right? If they're hooked up to suction, we really don't want to disconnect them from suction at any time. Okay? They can get up, they can mobilize within the space that this tubing allows them to go, but they need to stay hooked up to suction as much as possible. It's okay to disconnect them if they're going down for a procedure, but we want to hook them back up as soon as they get back to the room. Okay? So if we're starting to wean somebody down, we want to see if they're going to do well without a chest tube in place. They're going to place an order for what's called water seal, and so that literally means that you're disconnecting this tubing. Okay? And so your patient is free with just the chest tube attached to them. Okay? We're going to trial them for about 4 hours, sometimes overnight, to see if they have a reaccumulation of a pneumo or a hemo. If they don't, then we take it out. Okay? As far as dressings are concerned, there is a suture in place where the chest tube is inside the chest wall. You need to change that dressing every day and PRN. Okay? So sometimes they leak, sometimes they have saturation on the dressing, but they need to be changed PRN in every day. Because that's part of your assessment, right? So we need to be looking at that. When you do change the dressing for trauma purposes, we don't use Xeroform or Vaseline gauze because it's a vector for bacteria and can cause an infection, so we don't use those. The only time that we will use Xeroform or Vaseline gauze for a chest tube is if we're worried about a leak somewhere, and then usually our surgeon has placed that on the dressing. Okay. This is a collection container, right? So if we have a pneumothorax, we don't expect to be any output at all. If we have a hemothorax, we expect it to be blood, pleural effusion, maybe some different colored substances come out, right? So as this fills up, at the end of your 12-hour shift, we want you to write right on here with a Sharpie or some sort of marking your initials, date and time, so that way we can see when we walk into the room how much has been put out for the last 12 hours. In the chart, we want you to record every 4, just like normal, or in the ICU every hour, but we on the collection container every 12, so that we have a visual when we walk in. Okay. If they put out more than 200 an hour, then we need to be calling the surgeon and being concerned that they're putting out too much. If you first place a chest tube for the very first time, and their output will be higher. Okay. So after the first couple of hours that this is placed, then we worry about that 200 an hour. Okay. If a patient is transporting, you have the handles that come out of the top that can hang on the side of the bed. When the patient gets back to the ICU or the floor, wherever they're going, this will not drain unless it's below the level of the chest. So chest tubes need to be on the floor, okay? So if they're on the floor, sometimes they can be a little unsteady. They have a stand that they sit on. That prevents it from being knocked over. Things do happen, and they get knocked over all the time, right? So if there's output in the collection container and it gets moved, right? So say you have 30, 40, 50, you're not going to be able to record the output as accurately. So you want to change the chest tube box, okay? So you want to change the atrium. The way that we do that, this is attached to your patient, right? Attached to your chest tube. You want to clamp it. This is the only time for a trauma patient that you'll ever clamp a chest tube. You clamp it. You get out your new atria that is in this container right here. You depress and you pull. Okay. This is still attached to your patient. You get out your new atria and you reconnect. Okay. Do not touch the inside of this because this is going inside the chest wall and it's sterile in there. Okay. So you don't have to wear sterile gloves, but you have to make sure that you maintain sterile. Okay. And then you want to unclamp, and then you're good to go. Okay. How do you know if there is a leak in your chest tube?
You'll see bubbling. You'll see
bubbling, right?
bubbling.
Yeah. So intermittent bubbling is totally normal. So we're taking those deep breaths, or the patient's moving around the room. You're going to see some intermittent bubbling, and that's fine. But if the bubbling doesn't ever stop, if it's constant bubbling, then it's going to keep on.
Nice.
I'm sorry, I lost my train of thought. There's a leak, and it's going to keep on bubbling. So you want to always start at your patient, okay?
Okay.
This is what is inside your patient, okay? So there's a couple of holes here. Some other chest tubes have more holes. If you can see one of these eyelets sticking out of your patient, that's where your leak is, and you're pretty close to dislodging your tube. So you want to try to secure it as much as possible and call us and say, hey, my chest tube's about to fall out. The next place you'll look is here. This connection gets really tight sometimes, and it can get dislodged and cause leakage of air. So you want to check there. And then, other than that, this is your source. It can be your source for air leakage.
I guess the OR's using.
You do all of that, it's still leaking, then you call us and say, hey, come look at it. Who removes the chest tube when it's time for it to come out?
Physicians or nurse practitioners?
Physicians or nurse practitioners, not you, right?
No.
So when it comes out, you need to educate your patient that the chest tube dressing needs to stay in for how long?
It takes a while. I've been with the company a little over a year.
It's 48 to 72.
Okay.
Yep. So you want to write your initials, your date and your time. You want to educate your patient. This needs to stay in for at least 48 to 72 hours. When they're hooked up to suction, we already talked about that. They can walk around the room.
Right.
When they're hooked up to water cell, they can walk around.
I only emailed before, so it's nice to meet her.
They have no restrictions as far as that's concerned. But when they're hooked up to suction, they're limited to the space that this allows them to go.